Think forward. Think Research Channel.
Thank you very much for inviting me and for that kind introduction. I do feel as though I'm an honorary member of the lab medicine and anatomic pathology, having the Roger C. Haggett Chair and also with my colleague Karen Suchia. So what I'll do is I'll start out with this talk, and I'll first just highlight on what we're looking to accomplish here. And so the learning objectives to this talk are, first of all, I'd like you to be able to identify what the common mutations are and the epigenetic alterations that are observed in colorectal cancer. Secondly, to understand and just be able to describe the biological and clinical consequences of those molecular alterations, because it gives us some insight in terms of how and why we'd want to use these changes as potential molecular markers for the clinical behavior of the tumors. And lastly, to describe the clinical application of these molecular genetics to colorectal cancer management. And I'd like to bring you up to speed of where we are in 2008 with those types of assays. So to start with, what I'd like to do is give you a little bit of the epidemiology for colorectal cancer, tell you a little bit about what we understand about the clinical aspects of colorectal cancer care, and then we'll get into the pathogenesis and some of the biology, and then work our way towards the molecular markers. So first of all, colorectal cancer is common. It's one of the big three cancers, which includes breast, prostate, and colon. It affects roughly 150,000 people each year in the United States. Secondly, it's still deadly, and about 57,000 people die every year from colorectal cancer. There's about a 50% 5-year mortality rate, and that's largely because it's still almost half of the colorectal cancers that are diagnosed are advanced. Colorectal cancers are more difficult to treat. However, it is preventable, and we know that screening is effective for prevention. And one of the things I would like to highlight is, unlike other types of cancer screening tests, what's unique about colon cancer screening now is it's actually cancer prevention. And with colonoscopy, we can prevent colon cancers from occurring. And so there's a real opportunity here for colon cancer management. And then lastly, that it is treatable if we catch it early. And there's over a 95% survival for colon cancer that's detected in an early stage as compared to about a 5% survival for advanced colorectal cancer. So one of the things that we also know about colon cancer is we know a lot about the natural history. And what we know is that the vast majority of colon cancers form through something that's called the polyp to cancer progression sequence. And that's what's shown here in cartoon version. And so what we know is that colon cancers start with what's arguably the first lesion, which is an aberrant crypt focus. And then they progress to something called a polyp, which is a visible lesion that we can see on endoscopy. Then that polyp grows in size and can acquire high-grade dysplasia, what used to be called carcinoma in situ, and then that adenoma then progresses to adenocarcinoma, which then can go on to metastasize. What we also know is that there are certain molecular events that correlate with these histologic steps, and that APC mutations occur very early on and are thought by guilt by association and partly from animal models to associate with the initiation of this event. And Bert Vogelstein, who's done a lot of the groundbreaking work in this area, has called this the gatekeeper event. That's followed by mutations in other genes such as KRAS, which is thought to be involved with the progression of the adenomas, and then mutations in genes like P53, which are thought to be important for the malignant transformation of the adenoma to adenocarcinoma, and then other events such as amplification of a phosphatase called PRL3, which is seen in the metastatic lesions. Now, this polyp to cancer progression sequence takes a fair amount of time to occur, and that's really where the opportunity is in terms of screening and prevention, and that the polyp phase of this phenomenon takes anywhere from 10 to 15 years before this nascent polyp will go on to become a full-blown adenocarcinoma. If someone has the misfortune then of going on to develop an adenocarcinoma, it gets, the cancers get staged using the TNM staging classification scheme. And I've shown this to you here. And currently, in 2008, this is still the best schema that we have for now deciding how someone's going to do once they develop a colon cancer. And it's still the most accurate system that we have for prognostic purposes. So if someone has a stage 0 tumor, it's confined to the mucosa of the colon. For a stage 1 tumor, it's progressed beyond the mucosa, through the submucosa, and into the muscularis propria. For stage 2 cancer, it's gone through the muscularis propria, but no regional lymph nodes are involved. For stage 3 cancer, we have regional lymph nodes that are involved. And then for stage 4 cancer, there are metastases to distant organs. The difference in survival goes from nearly 100% to 95% to 85% to roughly 50% with no treatment other than surgery to less than 5%. So there's a dramatic decrement when we get to this more advanced disease where it's spread to the lymph nodes and to the distant organs. So really one of the keys here is trying to identify these tumors at a stage earlier than the stage 3 cutoff. So then what are our treatment options for colorectal cancer? And again, the reason why I'm bringing this up is because this is important to understand for what's going on now with molecular markers, particularly as predictive markers for treatment for colorectal cancer. So the primary option is surgical resection, and that's an option for stage 1 through 3 disease. So, and I'm oversimplifying things somewhat because there is a role for surgical treatment for distant metastases, but we won't dwell on that on this talk. So really surgery is the best opportunity to cure a patient. So as the surgeons like to say, to cut is to cure, and that's certainly true for colorectal cancer. Next, there are medical options for treating colorectal cancer, and for stage 3 disease, this is in addition to the surgery, so this is called adjuvant chemotherapy, and for stage 4 disease, it's basically palliative therapy that can prolong life. The conventional drugs that are used for treating colorectal cancer include 5-fluorouracil, and that's really the mainstay of our medical treatment for colorectal cancer. Virtually all regimens rely on 5-fluorouracil as a part of the treatment. Capecitabine, which is an oral form of 5-FU, oxaliplatin, a platinum derivative, or irinotecan, which is a topoisomerase I inhibitor. More recently, there are targeted therapies that have been shown to be effective for the treatment of metastatic disease. And these include the EGF receptor, monoclonal antibody inhibitors, cetuximab and panitumumab, and the VEGF receptor inhibitor, which is a monoclonal antibody called bevacizumab or Avastin. And these have been of particular interest, particularly cetuximab, and we'll talk about that later on. And then lastly, there is a role for radiation therapy for the treatment of rectal cancer, and that's used as a neoadjuvant therapy, so before surgery is actually done. So how do people do then with regards to response to treatment, and how does that affect survival? Well, first of all, it's stage dependent. So for chemotherapy that's given for stage 3 disease, we're really looking at trying to increase the number of people who obtain a cure with that treatment. Where for stage 4 disease, we're talking about prolonging life. So if we look at adjuvant therapy, the current regimen of choice is called FOLFOX, and that's for 5-fluorouracil and oxaliplatin, and it can change the number of people who have a 5-year disease-free survival from roughly 40 to 50% to 60 to 72%. So it's an improvement, but it's certainly not as though we're taking this to a 100% 5-year disease-free survival. So one of the important aspects to these statistics is that there are still a lot of people with stage 3 disease who do poorly, and we don't know how to identify those people. So what we know from the clinical staging scheme is that there's a lot of heterogeneity then, and that there are people who will do well and people who won't do well. Now if we look at the palliative therapy for stage 4 disease, the current regimen is 5-fluorouracil, oxaliplatin, and irinotecan. About half of people who have metastatic disease will show at least a stabilization of their disease or partial regression, and there's an increased survival to about 14-month overall survival. if we use cetuximab, what we find is that roughly 8 to 25% of people with metastatic disease will respond, and there's a 4-month increase in progression-free survival. And then if we look at the addition of bevacizumab, we see about a 2 to 4-month increase in overall survival. So slight improvements in survival, but certainly not what we'd be hoping for, which would be a cure for patients with stage 4 disease. So what are the central issues that I'd like you to keep in mind as we're talking about these molecular marker assays? First of all, prevention of colorectal cancer. And there's been a lot of work trying to identify molecular markers that can improve our ability to prevent colon cancer. We currently use colonoscopy as the screening modality, and that's very effective for identifying polyps and cancers. And because we can do polypectomies, it's also not only cancer screening, it's cancer prevention. However, roughly 20 to 40% of people are compliant with colon cancer screening, and so there's been an intense interest in whether molecular markers can be useful for improving compliance with screening programs. Secondly, we'd like to be able to use molecular markers for the selection of patients for adjuvant therapy. We'd like to identify optimal agents for patients with stage 2 and stage 3 cancers. So in other words, can we personalize the treatment of those cancers based on the molecular markers? Can we use a molecular marker to identify those patients who have stage 2 colon cancer who are at the highest risk of developing cancer? And one of the challenges here is that most of these chemotherapeutic agents have a fair amount of toxicity. And because the survival with stage 2 colon cancer is about 85% 5-year disease-free survival, that means that it's difficult to be able to show a benefit in that particular population because of the conflicting toxicity with the anti-tumor effects. And so what we'd like to be able to do is to identify those stage 2 patients who are at the highest risk for recurrence and treat those patients, because that would be an acceptable toxicity to response ratio. And lastly, we'd like to be able to identify those stage 3 patients who won't respond to treatment, so we don't treat them unnecessarily with certain drugs. We'd also like to be able to identify the selection of agents for stage 4 cancer and identify those agents with regards to the conventional treatment drugs, 5-fluorouracil, oxaliplatin, and irinotecan, that will show some benefit in order to minimize the toxicity and improve the overall quality of life, so that if we can't achieve a cure, at the very least we're not decrementing those people's quality of life. And then we'd also like to identify those people who have tumors that are likely to respond to the targeted therapies. And that's not only, again, for the same issues of toxicity, improving quality of life, but these targeted agents are quite expensive, and they can run up to $300,000 a year for treatment. And so if we can identify those people who are likely to benefit or not benefit, that will allow us to more wisely choose which drugs to use for patients with metastatic colon cancer. So then if we talk about the clinical applications for molecular assays, I've lumped them into 3 groups: molecular markers for early detection, prognostic markers of colorectal cancer for looking at overall survival, or if we look at metastatic disease, time to progression, and then predictive markers, so ones that will identify which treatments are likely to be effective, and that's in regards to either the conventional chemotherapy or the targeted agents. One of the things I'd like to do is just take a moment to highlight, when we're talking about these molecular genetics, it's important to keep in mind that when we're talking about tumor genetic markers in colorectal cancer, that there's a difference between germline mutations and somatic mutations. And partly I bring this up because I've even had personal experience where molecular marker assays using tumor-based markers have been used to inaccurately diagnose someone with a cancer family syndrome. And this has come up with some of the marker assays for stool samples, where someone's had a molecular marker done on a stool sample found to have an APC mutation and was told that he had familial adenomatous polyposis syndrome. And while there are mutations that can create a susceptibility to cancer, and these are germline inherited mutations, and what's shown here is this individual who carries this mutation in their whole body and is predisposed to developing a cancer. What we're going to be talking about are somatic mutations, and these are mutations that occur in the tumor itself and then are used as molecular markers, either by looking at the tumor itself or by looking at what we call remote media in the jargon, which means blood or urine or sputum or stool that in which the tumor DNA can be detected and used as a molecular marker for the presence of that tumor in that individual. So which molecular markers are we going to use? Well, what I'd like to do is take a moment to talk about the pathogenesis of colon cancer from a molecular level. And so what I've shown you here is that polyp to cancer progression sequence with normal epithelium going through the polyp or adenoma phase to cancer and then metastatic cancer. What we know is that about 85% of colon cancers are formed by what's been called the chromosome instability or microsatellite stable pathway, which is marked by aneuploidy, and that there are mutations that commonly occur in the tumors that we see that arise via this pathway that include APC, KRAS, P53, and PRL3. However, what's also true is that there are other tumors that form by a different pathway that can be characterized by the form of genomic instability that these tumors show. And this is a pathway that's called the microsatellite unstable pathway, and this accounts for about 15% of sporadic colon cancers. And it's caused by inactivation of the mutation mismatch repair system. We see similar mutations to those that we see in the CIN pathway, such as in genes like APC, but then we also see mutations in other genes that are unique to the MSI tumors, like mutations in BRAF or mutations in genes like BAX and TGF-beta-R2 in particular locations in these genes that are susceptible to mutation in the setting of the loss of mutation mismatch repair system. So we have some molecular heterogeneity in these tumors. What's also true is we know that there are some tumors that show a unique epigenetic pattern or a form of epigenetic instability. And these are tumors that have been called the CIMP pathway, which is the CPG island methylator phenotype. And these are tumors that are marked by an excessive amount of DNA methylation. What's true for almost all cancers, including colon cancers, is that there are some genes that are aberrantly methylated and silenced by the aberrant methylation of the promoter region of the genes. About 20% of colon cancers show an excessive amount of that aberrant methylation, and these are what are called the CIMP tumors. So if we look at it with regards to the different, the world of colorectal cancer from a molecular standpoint, we can divide it up into tumors that show CIN or chromosome instability, or what's been called microsatellite stable tumors, in contrast to microsatellite unstable tumors. And then we also have these CPG island methylator phenotype colorectal cancers. So if we go back then to those clinical applications of molecular assays, can we use any of these molecular assays in the tumors that highlight the molecular heterogeneity of the tumors to then predict the behavior of the tumors, or can we use them as early detection markers for colorectal cancer? So which ones would be potential markers for colon cancer? And what I'm showing you here again is that same iconic version of the polyp to cancer progression sequence with some of the common mutations that we see in the colon cancer sequence. And the markers that we'd want to identify, I would argue, would need to be in this area, which is in the adenoma at latest to the early colon cancer stage, because it doesn't make any sense to detect an advanced cancer that is beyond our ability to treat it at this stage. So which of these have been looked at to date? Well, a number of them have been developed and tested in a variety of forms as molecular marker assays. And the genes that I'm showing you in pink here are an example of some of those genes. So one of the challenges, though, for using molecular markers or using these genetic alterations as screening markers is that what we're trying to do is we're trying to use the marker as basically a surrogate for identifying a tumor cell in that individual. And we're looking for the tumor DNA somewhere remote from where the primary tumor arose. And so it's much like trying to find the needle in a haystack. What I'm showing you here is an example of this with a stool-based assay. And the challenge here is that if we use stool as the source of DNA for the molecular markers, what we have to do is we have to identify DNA coming from the tumor that's in a background of normal DNA. So it's kind of like, where's Waldo? And so we have to develop a way to isolate that tumor DNA and then detect it in some fashion. And there's a huge challenge there to doing that, The reason why I'm showing you a stool-based assay is that despite that being a huge challenge, there actually are stool-based molecular assays that are currently available for colon cancer screening. In my laboratory, we're working on the next generation of those assays, and we're also looking to see, can we use these molecular assays in a blood-based or a urine-based assay for early cancer detection. And I'll just show you the steps that we go through in my laboratory, which are true for anyone who's working on molecular marker assays for colon cancer screening. And then initially what needs to be done is an optimization step of a particular type of assay, and the markers that I'm particularly interested in, or my laboratory is interested in, are markers of methylated genes, and so we use a technique called methylation-specific PCR, and we've tweaked these assays to increase the sensitivity of the assays so that we can get down, and what you can see here are different genes listed, but we can get down to about a 5 picogram range in terms of the absolute minimal limit of DNA that we can detect, which is roughly 1 cell's equivalent. And that's about the range that you need to be in for a molecular marker assay to work. And then the next challenge that we've had to work on is, how do you then optimize the recovery of the DNA from the different samples, stool, urine, or blood, so that you're enriching for the tumor DNA, so that you're able to pull out the DNA from that remote media and then apply your assay to it. And so when we've done that for stool assays, what we find is we can develop assays that are about 50% sensitive and about 90% specific for the identification of colon polyps. We can also do this, interestingly, in urine with a much lower sensitivity but a high specificity of about 100%. So these are some feasibility studies that we're working on using methylated genes as markers. So what's currently available then? What if you wanted to get a molecular marker assay? What are your options? Well, in 2008, there are some options, and these molecular marker assays are, the indication for them is for those individuals unwilling to undergo other accepted screening tests. And currently in the United States, the most accurate test that's available is colonoscopy, and that's the one that most of us are recommending. But if you wanted to do a molecular marker test, your option is a test called Colorectal, which is commercially available as of this year, and it's offered by LabCorp. There's another test that may be offered soon that's called SDT2, but it's only available on a research basis, and it's been run at the Mayo Clinic. So what are these tests based on? Well, what these tests are, they're stool DNA-based tests. So basically you get a bucket, put it in the toilet, deposit your sample, close the bucket up after you add some stabilization buffer to the stool sample, and then mail it to LabCorp. And then they have some very lucky people who get a chance to extract the DNA from the stool, and then they run these assays on the DNA extracted from the stool samples. So the assay that's the Colorectal assay is based on methylated vimentin. The SDT2 assay adds assays for mutant KRAS and mutant APC. So how well do these assays work? Well, for the Colorectal assay for colon cancer, it's about 81% specific, and you can see the 95% confidence interval here, and about 82% specific, so 81% sensitive, 82% specific. For the SDT2 assay for colon cancer or for advanced adenomas, this is about 40% sensitive, and the specificity wasn't calculated. How does that compare to colonoscopy? Colonoscopy is over 95% sensitive and about 100% specific for identifying colon cancers, and for advanced adenomas, it's not too much less than that. So this assay is good, but it quite doesn't meet the benchmark of colonoscopy. This assay, though, is non-invasive, where colonoscopy requires sedation and an invasive procedure. How much would this assay cost? Well, it depends on if your doctor orders it or if you call LabCorp up and want it yourself. If a physician orders it, it's $200. LabCorp will charge $240 for any individual calls without a physician ordering it. So where are we then with the current status of commercial molecular marker assays? Well, for any of you who are savvy to this field, you'll know that there was a pre-Colorectal assay that was available called PreGen Plus that cost about $800, and it's no longer commercially available. So LabCorp dumped this assay, and now they're offering the Colorectal assay. This was determined to be an acceptable assay per guidelines from the United States Multi-Task Force, American Cancer Society, and American College of Radiology. It's considered to be an alternative to colonoscopy. So you could call this a mother-in-law test. So, good enough for your mother-in-law, but not for your mother. Does require colonoscopy if it's positive, and there's an appropriate interval for testing is unknown. So if you test negative, should you get tested again in 6 months, 12 months, 2 years, 3 years? We don't know. So there's a lot of unknowns to this test, but it is probably the most successful molecular marker assay for screening to date. All right, so what happens if we move away now from early detection and now we start talking about those unfortunate people who do develop colon cancer, and how can we use molecular marker assays from a prognostic standpoint or from a predictive standpoint? So if we go back to this molecular heterogeneity, that's really where the opportunity is for a molecular marker assay. If there was no molecular heterogeneity in colon cancer, then there really wouldn't make any sense for looking for molecular markers to help better determine which of the risk groups based on TNM staging can we further stratify to better determine what the behavior of those tumors is going to be. So one of the questions is, can we use our current understanding of this molecular heterogeneity where tumors are grouped into microsatellite stable, microsatellite unstable, or SIMP tumors as prognostic markers for these tumors? What about microsatellite unstable cancers? Well, what I'd like to do is just briefly show you which players we're talking about drive the formation of microsatellite unstable cancers, because these mismatch repair genes are used as molecular markers currently. So the players here, the mutation mismatch repair genes that we're talking about, are two of them that are shown here called MSH2 and MSH6. And the way these work is that they work as a clamp that recognizes a base pair mismatch, or MSH2 can partner with a different partner, MSH3, that can recognize an insertion or deletion loop. And then what happens is that ATP is involved with binding to this clamp and then recruits as a molecular matchmaker essentially another set of dimers of proteins called MLH1 and PMS2, or you can have MLH1 and PMS1 and MLH1 and MLH3, and these names are really boring names that were derived from yeast studies where they basically mutated yeast, and that's where they come from. That's where it's mutator homolog 3, mutator L homolog 1. But you've got these different partners that are involved, which then normally repair these defects. And these can be inactivated in sporadic colon cancer. The most commonly inactivated of these mutation mismatch repair genes is MLH1. But MSH2 is also commonly inactivated in a cancer family syndrome that leads to colon cancer formation as well. So those are the genes that are involved. The consequence is something called microsatellite instability. And again, I'd like to take a minute to talk about that because this is something that we do analyze for in the laboratory, and it's important to understand what we're actually measuring. So what microsatellite instability refers to are frame shift mutations that occur in repetitive sequences of DNA that are usually dinucleotide or trinucleotide or mononucleotide repetitive elements. They're scattered throughout the genome. They're usually in intergenic regions of the genes or in intronic regions. And what's true of them is that they're basically repetitive elements that show a lot of length variability, so that if we look at any individual, usually the two alleles of those individuals will vary in size. What that allows us to do then is to measure the length of these assays using PCR-based assays, and these are PCR primers shown here. So what we can do is we can run a PCR assay and then run the amplicons out on a size separation gel and look to see what those sizes look like. And if we do that, what we see is the germline DNA will show the two different allele sizes. Normal tissue will show those same alleles. But in a microsatellite unstable tumor, because of the insertions or deletions, we see a change in the size of that allele. And that's how we characterize microsatellite instability. Formally, how that's done is that there are 5 different regions or loci that we look at, and then if we see more than 2 of 5 of those regions that show this microsatellite instability, the tumor is characterized as having microsatellite instability. The importance of that is that tells us that the mutation mismatch repair system is inactive in that tumor. And as I mentioned before, for sporadic microsatellite unstable tumors, which account for about 15% of cancers, that's because of inactivation of MLH1. And what's interesting is that's through an epigenetic event. So it's methylation of MLH1 that then leads to genetic abnormalities in the tumors. But what's also true of microsatellite instability is that it's a marker for a familial colorectal cancer syndrome that's called the Lynch syndrome, which is caused by germline mutations in these mutation mismatch repair genes, and the most common ones being MLH1 and MSH2. So can we use microsatellite instability as a prognostic marker? There have been a variety of studies that have been done looking at that, and what I'm showing you here is a synthesis of that. That was a systematic review published in Journal of Clinical Oncology by Poppet in 2005. And this is a funnel plot showing overall survival in studies of stage 2 and 3 colorectal cancer with microsatellite instability. And what you can see is that some of these studies show an overlap here over 1. But on average, if the hazard ratio is slightly less than 1. So this is what this data is showing you is what's the likelihood of a tumor that has a favorable prognosis having microsatellite stability. So it's a little bit inverted in terms of the way you think about it. The upshot is basically what this tells you is that on average, tumors that have microsatellite instability show a better prognosis than tumors that don't have microsatellite instability. But there's enough variability in these studies that currently we don't recommend using microsatellite instability as a way to further prognosticate tumors clinically. Well, how about using these as a marker for prediction for response? If the fundamental defect is an inactivation of a DNA repair system, maybe that would suggest that there's a susceptibility to damage caused by chemotherapy in those tumors that have turned off the mutation mismatch repair system. And so that's been looked at as well. And what I'm showing you here is a study that was done using the currently clinically accepted marker for microsatellite instability, where tumors that were from 4 different NSABP studies were grouped together and analyzed for microsatellite instability and then response to treatment. So these include studies that compared BCG versus an outdated regimen called MOF, 5-FU given by the portal vein versus surgery alone, 5-FU with leucovorin versus MOF, and 5-FU leucovorin versus or plus minus levambisol. These treatments now, like the BCG and MOF, are basically considered to be as if you're giving nothing, because we know that they don't work at all in colon cancer. So if you look at the recurrence-free survival and the overall survival, what you see is a slight improvement in the recurrence-free survival, but no effect on overall survival with microsatellite instability. So in essence, showing no effect of microsatellite instability or no ability to predict response. So if we look at this in another way, and the reason why I want to show you this data from another systematic review that was published by Grem in the Surgical Oncology Clinics Journal, is that there's been a lot of interest in trying to use microsatellite instability as a predictive marker. And that comes from a variety of other studies that actually have shown that microsatellite instability predicts a favorable response to 5-fluorouracil. So you can see in this study, there's a 90% 3-year overall survival compared to a 62%. Here, there was a 68 versus a 56% improvement. But if you look at other studies, such as this one, you see that basically there is no difference in survival. So we have studies going both ways, and in fact, there's an additional study as adjuvant therapy that actually shows that people with microsatellite unstable tumors may even have an adverse effect. And then lastly, what if we look at it using it in stage 4 colon cancer patients? There's a slight suggestion of an improvement. Now, what's a challenge with these particular studies is that we don't see many microsatellite unstable metastatic tumors because of this probable effect on prognosis, and that microsatellite unstable tumors are less likely to progress to stage 4 disease. All right, so basically what I've shown you then is that although there's been a lot of effort put into this, microsatellite instability is certainly not a hands-down winner as a predictive or prognostic marker. So what about aneuploid or chromosome unstable tumors? Can this be used as a way as a prognostic or predictive marker. So there are different ways to measure chromosome instability: flow cytometry or image analysis. Now, the mechanism that causes chromosome instability has been much more of a challenge to figure out, and there are a variety of potential candidate mechanisms. And what I've shown you here is just a few examples of those. And the reason why I'm showing you this is that, again, if we could find a marker that suggested a particular defect in a tumor that might be important for whether the tumor can respond to a certain type of DNA damage, that has a lot of biological plausibility to be used as a predictive marker for particular chemotherapies. So these mechanisms then involve spindle checkpoint, kinetochore regulation, DNA damage checkpoint at G1, replication checkpoint or inter-S replication checkpoints, or DNA damage checkpoint at G2. So if we use chromosome instability as a surrogate marker for an inactivating event in one of those checkpoints, what do we get? Well, this is a systematic review of roughly 48 studies that have been done looking to see whether chromosome instability or aneuploidy can be used as a prognostic or predictive marker. And this is a summary of hazard ratios. And what you can see, what I like to really draw your eye to on this table here are the hazard ratios. If we look at overall survival or progression-free survival, there's a slight prediction of a worse prognosis in individuals who have aneuploidy as marked by an increase over 2N DNA content. If we look at whether it makes a difference for anatomic location of the tumor, so do colon cancers versus rectal cancers show more aneuploidy? We don't see any evidence of that. We don't see any evidence of an association with stage of disease, with stage 2, 3 disease. And we see maybe a slight suggestion of an improvement, or a prediction of a worse prognosis, so improvement in those tumors that don't have aneuploidy in treatment with a 5-FU-based regimen. So there's a slight suggestion that maybe aneuploidy could be useful as a marker. However, the current recommendations from the two major organizations who set guidelines, which is from the American Society of Clinical Oncology or the European Group for Tumor Markers, suggest that the assays still aren't quite robust enough for this to be useful as a clinical assay for predicting response. All right, so what about the last molecular group, SIMP tumors? Well, one of the challenges here is that there's still a lot of arguing to the point of actually bringing people to tears at some of the national meetings. However, how do you define SIMP? And it's not clear. And the problem is that we don't know what the underlying mechanism for the aberrant methylation that we see in these tumors is. So unlike with microsatellite instability, where that suggests an activation of a mutation mismatch repair gene, we don't know what SIMP is really identifying. And so people have spent a lot of effort trying to find markers that would suggest whether a tumor is this unique molecular group of SIMP. And what I'm showing you here is a variety of different markers that have been suggested to be appropriate for diagnosing SIMP. So some of the genes in this group, there's another group called SIMP1, another group called SIMP2, and then one question is, do we have tumors that show an in-between, a non-SIMP and a SIMP state of SIMP low? And right now there's basically just a lot of arguing and people calling each other snails and a lot of carrying on trying to figure this out. So where does that leave us? Well, what I'd like to do is just highlight one set of the markers that seem to be plausible and reasonable to use as markers for SIMP. And these are from a study that was published in Nature Genetics a couple of years ago and from Peter Laird's lab. And he looked at a variety of markers, about 200 markers, and he found that these 5 in particular associated with tumors that had very commonly had mutations in the BRAF gene and also associated with microsatellite instability. So he suggested, because of this association with BRAF, that these tumors were a unique molecular subgroup. So if we again go back to the world of colon cancer from a molecular standpoint, the way we could see it now would be that there are about 85% of colon cancers that show chromosome instability. Some of those also show CpG methylator phenotype, and the majority of the tumors that are microsatellite unstable also are in the SIMP group, but then there's a small fraction that are not. So can we use SIMP as a prognostic or predictive marker? Well, there have been 4 studies to date so far, and they're actually mixed. So some say no effect on prognosis, some say better effect, some say worse effect. So it's hard to say. So what's the current status? Well, it's research only. And so it may be that there'll be an NIH consensus conference where at least some common standards will be used to diagnose SIMP. So again, in summary, for these molecular subgroups as molecular markers for colorectal cancer, where are we? Well, we know that for microsatellite unstable colon cancers, it's not recommended for use as a prognostic marker or a predictive marker, but it is used as a screening marker for those people who have that Lynch syndrome or HMPCC. What about chromosome instability as a prognostic marker or predictive marker? No, not yet. And what about SIMP? No, definitely not yet. So there's still a lot more work to be done. So where does that leave us? Well, it says, well, maybe there are other molecular markers that we could look at other than these molecular subgroups. So again, if we look back at this polyp to cancer progression sequence, there are a lot of other specific genes that we could analyze. So maybe one of those would be a better marker than this kind of global molecular characterization. So what are the potential candidates? Well, I'm showing you here just a whole variety of different genes that are potential candidates that have been looked at and published in what I call little boutique studies, where someone will take their favorite gene, analyze a set of tumors, and then look to see how that response or how that correlates with the clinical response. What I've shown you already is that for this group, the chromosome instability group, that hasn't played out so far. So what about these other ones? Well, unfortunately, it's a sad story of many broken promises. So there are a whole slew of studies that have been done that have suggested all these markers and more look great as predictive or prognostic markers. But what I'd like to show you is a few of those and where things stand, and then after all that and shaking out, where are we now in 2008 with any of these molecular markers as being predictive or prognostic markers. So what about P53? P53 was one of the first tumor suppressor genes identified. It's the guardian of the genome. There have been studies done that have included over 18,000 patients looking at P53 as a molecular marker for colorectal cancer. And again, I'm showing you a summary here from a systematic review from Monroe that was published in the British Journal of Cancer that has looked at a variety of these different studies. The studies have used immunohistochemistry and they've used mutation analysis predominantly. And what I'd like to have you focus on this busy table is right here, the relative risk. So you can see these studies have shown a modest relative risk, suggesting the P53 mutation is an adverse marker for predicting response or prognosis of these tumors. But if you then go and look over here at these two columns with the Begg and Eggers, what these refer to are what's the statistical significance when you correct for things like publication biases and heterogeneity in these studies. And what you can see is that the majority of these studies have non-significant results. So where does that leave us? That leaves us basically with the conclusion that there's no definite prognostic value or predictive value for P53 in relationship to 5-FU-based therapy, which is what this looked at. So unfortunately, P53 is not going to work. What about another set of candidate proteins that have been looked at, which are a set of enzymes that are involved with metabolizing 5-FU, called thymidylate synthase, or TS, thymidine phosphorylase, called TP, and dihydropyrimidine dehydrogenase. So what do these do? Well, I'd just like to show you where the action is. So TS is involved in converting DUMP to DTMP, and this is the enzyme where we think most of 5-FU's activity is, because 5-FU blocks thymidylate synthase. But thymidylate phosphorylase is involved in the conversion of FD-DURD to FD-DUMP, and DPD is involved with converting 5-fluorouracil to a non-active metabolite. So you could imagine any tumor that overexpresses any of these enzymes, you would predict would be less likely to respond to treatment. So how did things play out then? Well, this is that review from Graham, 2005, looked at TS as a potential predictive marker, and TS can be measured by mRNA or protein level. And what you see is the bottom line here is if you look at the outcome, you can see in this study where tumors that had low TS versus high TS were analyzed, there's a better response in those tumors that have the low TS versus the ones that have the high TS. And that's also true with an 80% response compared to a 60% response to that high TS rate. So that's true of a few studies, but also there are other studies that didn't see any effect. So here we go again. So some studies show a benefit, some studies show no benefit. So where does that leave us? Well, it leaves us, unfortunately, with not having a robust marker that we can use for predicting response to treatment. So for conventional chemotherapy agents, we really don't have a strong predictive marker. So what if we move over to these targeted agents? And the one I'd like to highlight, because there's been a lot of activity over the last couple of years, is markers for EGF receptor inhibitor therapy. These markers have become really the darling of the field. And I'm on the committee for setting up the next GI Cancer ASCO symposium, and we must have gotten half our abstracts that were submitted were based on using KRAS as a marker for response to EGFR inhibitor therapy. So why would you want to use the EGFR inhibitor therapy in colon cancer? Well, many of the ligands that are included in the EGF family, EGF, epiregulin, amphiregulin, are overexpressed in colon cancer. Some colon cancers overexpress EGF receptor itself, and this is just shown as a cartoon version of a much more complicated receptor family. What we know is that EGFR then activates downstream signaling pathways, including the MAP kinase pathway, and one of the key players here is RAS, which when activated then can activate the MEK signaling pathway or the RAF-MEK-ERK signaling pathway. So I want to highlight these things because these are all potential markers for predicting response to the EGF receptor inhibitors. What's furthermore, and the reason why they're potentially interesting, is that mutations in this signaling pathway, particularly in KRAS, are common in colon cancer. There's a 30 to 50% frequency, less commonly in NRAS, but we also see mutations in BRAF at about 10%. So it suggests that these could be good markers for dissecting out differences in responses to the EGF receptor inhibitors. And the reason why people got particularly interested in this is that we know that there are some non-responders to EGF receptor inhibitor therapy. So one of the better done studies that was published this year was a study that looked at mutant KRAS, which is activated, it's an oncogene, and whether it predicted response to therapy. It was a study that was a phase 3 open label study, looked at best supportive care or treatment with panitumumab, which is a humanized version of a monoclonal antibody that's against the EGF receptor that was approved for use in 2006. And what you can see is if you look at the tumors that have mutant KRAS, the two lines basically overlap, so no effect. But if we look at those that have wild-type KRAS, you can see that there's a substantial improvement in progression-free survival in those tumors that are treated with panitumumab, which is shown with the blue line. So now, how about if we look at the other studies that have been published over the last couple of years? And this is from a systematic review that was just published in Lancet Oncology this month. And what you can see is if we look at some more funnel plots and we look at the sensitivity versus the specificity for mutant KRAS, what you can see is that it has a modest sensitivity, so it's not necessarily a very good positive predictive marker. So if you have a wild-type KRAS, it's only about a 30 to 40% chance that you'll respond to therapy. But if you have a mutant KRAS, it's a very strong negative predictor. So basically, mutant KRAS means no response. Wild-type KRAS means maybe a response. So there's still a lot of tumors that have wild-type KRAS that have some other mechanism for causing resistance. And I think that's an area that's ripe for research. So where things are locally is that Colin Pritchard and Jonathan Tate are developing assays for KRAS. And I'm just showing you one example that Colin was kind enough to share with me of an analysis on a patient showing an assay using a light cycler melting curve, how you can detect that mutant KRAS allele. And Colin's designed an assay to look for the most common mutations in KRAS, which are in exon 2, and using those as a way to identify those tumors that are likely not to respond to EGF receptor inhibitor therapy. And for colon cancer, that means cetuximab. All right, so where are we then? So these are the money shots here. So in summary, what do we have to work with in 2008? What specific molecular markers are there for colorectal cancer? Well, what about P53? Now, and the reason is there's not a robust assay to date. P53, the molecular pathology, is very complicated. I think the problem is the assays we've used to date just haven't really address that level of complexity, and that's the reason for the variable results. What about TS or DPD or TP, those enzymes that metabolize 5-FU? No, same problem, lack of a robust assay. And it's primarily these assays relied on immunostaining. What about KRAS? Yeah, I think yes, although we're on the cusp of getting that approved. The FDA has actually required that KRAS mutation status be determined in a tumor before approving use of panitumumab. Now, we've already kind of been there and done that with using EGF receptor inhibitor therapy. The last marker the FDA was requiring was the EGF receptor immunostaining, and that turned out to be, if I say something incorrect here, a really dumb idea. Because it turns out that EGF receptor immunostaining didn't correlate at all with the response to treatment. But KRAS is actually looking pretty good. What about using FISH for EGF receptor? Well, that one actually looks to be more robust at the clinical level, but it turns out there's a lot of intertumoral heterogeneity. And there have been some studies that have been published that have shown that that heterogeneity is so high that it really becomes a challenge with, well, how do you accurately score FISH and correlate that with clinical response to treatment? So I think that's one of the issues that may be in play with using EGFR as a marker. So in 2008 then, what do we have available? Well, what we have available is we have microsatellite instability or immunostaining for the mutation mismatch repair genes as a diagnostic screen for colon cancers that might be arising in someone who has HMPCC. We have methylated vimentin as a colon cancer screening test. Mutant KRAS as a predictive marker for response to cetuximab or panitumumab. And then maybe someday we'll have loss of heterozygosity of 18q as a marker for aneuploidy, or overexpression of TS as predictive or prognostic markers. But currently they're only recommended for research use. So to put this in the context of this polyp to cancer progression sequence, I've shown you in yellow a lot of the different markers that have been looked at, but the ones in orange are the ones so far that look like they're clinically robust enough to be useful in 2008. And with that, I'll finish, and I'd be happy to take any questions.
Questions for Dr. Gray?
Yeah.
Just a question, because I would agree with you. You said EGFR immunohistochemistry is a stupid idea. I think it's a stupid idea, yet people still ask for it in this institution. They also still ask for thymidylate synthetase immunohistochemistry for that same purpose in this institution. I think we need to get the word out on that.
Yeah,
I would ask you a question about EGFR. We know that it's probably not a very good predictor in large part because it's downstream effectors like KRAS that probably have more to do with the storage. But is there still some value in doing the two together so that you know which patients you don't need to test KRAS?
Well, that's a really interesting question. I think partly we don't know, and part of the challenge here, I think with the immunostain assays, my take on it, and I think you and Melissa probably are a little bit closer to this, is that one of the big challenges and why these haven't turned out to be robust assays is that there hasn't been enough attention paid to how do you actually score what's going to be considered to be a positive or a negative. And I think that's going to depend on having a set of samples that's well enough clinically annotated where you'll be able to develop ROC curves that are going to be based on the clinical response and then use that to set what the scoring parameters are. And then also, how important are things like intertumoral heterogeneity? To me, one of the things that was I found fascinating was a recent study in the New England Journal of Medicine where a group looked at in patients with non-small cell lung cancer, and they looked at circulating tumor cells, and they could type them whether they had EGF receptor mutations or not. And what they could identify is in patients who later went on to become refractory to treatment, that there was a subpopulation of tumor cells that had EGF receptor mutations that would be predicted to be non-responsive to that therapy. So in essence, what you're seeing is a classic Darwinian evolution, is that there was a subgroup of tumor cells that you couldn't detect initially unless you looked very carefully using methods like deep sequencing methods that then would be selected for in response to that treatment. And so that's one of the other ways that we can think about this, but it becomes more challenging if we look at the tumor itself and want some marker that's going to predict a response, because maybe the important cells that we want to look at are only a subset of the whole tumor mass. So how do you address that by looking at a section from a tissue block? And I don't have any specific answers for that, but I think it does raise a big question about which markers will actually be useful as intertumoral markers for predicting response to therapy. Mm-hmm.
I wanted to know, so some of the assays that you were talking about, the MSI and, say, immunohistochemistry or P53, mostly predict sporadic changes, but there is a chance that they actually could find a germline, because people do have whatever Li-Fraumeni syndrome or this a germline problem with MSI, or for that matter, then moving on to a screening test, like a stool or something that was based on these genes. These things could be genetic tests. Does that mean that for a screening test based on these, or for that matter, which I don't think we do for immunohistochemistry, we should be consenting patients for genetic testing because it does have implications for their family for this diagnostic test, which we would otherwise do if they were, say, getting a Huntington's disease test?
Yeah, that's a great question, and that's another one. If you want to get a lot of people hot and agitated at a national meeting, ask that question because it's a big issue. When is immunostaining for mutation mismatch repair genes or testing for microsatellite instability a genetic test that requires genetic counseling and consenting to patient, and when is it a more conventional assay that we run on tumors that really is just a marker of a somatic change? I could argue both sides for you, and I think what you'll find is that the policies are mixed across the institutions.
So most of the data you looked at looked like it was sort of single parameters. Is there any value in combining these different tests together, or these different questions, and trying to get some sort of summation view of what the tumor is?
Yeah, no, I think so. That was the initial intent behind, for instance, the molecular marker assay that was this pre-Gen Plus assay. That actually had 30 different assays in it, and the idea was to capture all the tumors that would be represented across the spectrum of colon cancers, because we know there's this molecular heterogeneity. And it turned out that the problem was that some of the assays worked well and some of them didn't work well with regards to sensitivity and specificity. And so in aggregate, it actually brought down the overall value of the test. Now, there would be ways I think you could address that with weighting the performance of the tests, and people are starting to get into that. But to date, there hasn't been any assay that's been shown to be effective that's included a panel that have been differentially weighted for colon cancer. Now, I do think that that's probably true for breast cancer with this assay that I'm going to blank on the name of the company. I think Genome Health is offering. Right. Right. So in that one, I think that software, though, as far as I know, is still black box. So I'm not sure exactly how they're doing it.